We want to thank everybody for coming. For me, I've been here for 20 years as well. You've got a lot of longevity for staff members that are sitting in this room right now. And then Lisa and I have worked together to bring age-friendly here to Monadnock Community Hospital. I'll talk a little bit about that in a little bit. Okay. So the presentation objectives for today, we need to know nationally, we know we have an aging population. We know this is not like unique to New Hampshire. It's everywhere in the country. We're going to talk a little bit more about how we're helping at Monadnock Community Hospital. We want to make sure that we're taking care of our patients, and we're going to talk a little bit about the age-friendly initiatives that have been implemented on both the practice side as well as the inpatient side, and how this affects you. And it's not just you folks that are 65 and over, but we've got people too that are caring for loved ones that are 65 and over. We want to make sure that we're giving everybody the tools that they need to do this. I mean, care changes. What your goals used to be in your 30s is not what your goals are in the 70s. Things change. So we want to make sure that what's important to you, we're meeting that metric. Okay. So aging population, we know 10,000 baby boomers will turn 65 every day until 2030. That's a huge shift. Not only is that happening, total life expectancy is also getting longer. In 2010, it was 78.7, and now in 2030, it's projected to be 81.7 years. Okay. We need to make sure that we're adding quality. Yes, we're getting longer, but the point is we want you to have quality, and that's part of why we're all here today. So New Hampshire is among 25 plus states that are projected to have over 20% of their population be over 65. This is affecting policies that are being made, communities, how things are designed. So it's a big thing. So from a national response, we recognize that there's a lot of people that are over 65. So the Institute for Healthcare Improvement, IHI, they developed certification programs back in 2018. And Lisa and I worked together. Lisa was the pioneer. I'm going to call you the pioneer. In September of 2024, she brought age-friendly. She worked with the teams over in the practices and brought the age-friendly participant designation to the practices back in 2024. And then in June of 2025, Lisa and I were speaking like, hey, can we do this for the inpatient side as well? Because I've been here so long, I've been involved with a lot of places, and part of my job is implementing some of these initiatives hospital-wide. We were able to do that as well. And the hospital has also received that designation as of June 2025. So we want to make sure with Lisa and I, there's lots of things that have happened that we've put into place. Workflows have changed. We want to make sure what matters to you is what we're going to be able to provide for you. Okay. So this is what we've had adopted. So this is age-friendly care. And we have 4 different areas that we're going to be looking at. What matters, we want to make sure that, again, we're providing the care that matters to you. We can come up with a care plan and think it's great, and you'll be like, I'm not doing that. That's not important to me. Why would I do that? So we need to make sure we know what matters. Medication-wise, sometimes, there's certain things as we age, medications act differently. So that's what Mike will talk about in a little bit to help us navigate through some of that. And mentation, things change cognitively again, so we want to make sure that everybody has what they need and we can help care for people. And that is what Carolyn's going to be speaking about. And then mobility. We have to remember, we have to be proactive as well. We want to make sure we keep people moving. We're looking at things like fall prevention and things like that. And preventing falls is not just a mobility thing. It could be a medication thing as well. It could be a mentation thing. All of these things relate to each other. And we'll talk a little bit more about that as the seminar goes on. Okay? All right. So here are our presenters today. They have already introduced everybody for that. All right, and the first presenter is going to be Lynn Maloney, and she's going to talk a little bit about mobility. Okay.
All right, well, welcome everybody. My name is Lynn, like they said. I've been a physical therapist since 1984. I will be celebrating 25 years here May 1st. But that's the second time around. I was here in the early 90s, from 90 to 93, when we built the new hospital. And then I moved away for 8 8 years to Baltimore and came back. And I just love this place. So I love talking about mobility, and I am now officially moving up into that baby boomer, age-friendly, aging gracefully. Just had my own physical with my PCP this morning, and boy, we changed the tone of you know, what we're looking at and maybe why and all those things. So I kind of just came right off of that this morning. So yeah, 40-something years being a PT kind of flew by in a fast. So yes, mobility. And we're not calling this fall prevention. That's what we usually talk about. But why do we care about mobility? It's, yeah, one of the 4 M's. But it's navigating. It's figuring out how we move as we get older and how to keep ourselves safe. But the biggest thing, if nothing else, just keep moving, whatever that looks like to you all. You know, that's what's so important. It's when we sit on the couch that everybody else is lapping us as they walk around us, okay? Key elements to being able to keep your mobility is your strength and your balance, regular use and motion, like I just said, keeping moving, whatever that looks like, and we'll talk about some options. Your vestibular system. How many people know what the vestibular system is? Okay, that's your inner ear system. Everybody ever hear about having vertigo? Right? Yeah. Well, our vestibular system is an organ. It's an inner ear organ. And so you've got one on either side, and the whole thing's the size of a dime. It's your internal leveling system. And if that goes a little wonky for whatever purposes and reason, it can throw your balance off, okay? But it's an organ, and like other organs in our body, they kind of slow down and kind of change how well they're functioning. So you don't have to be full out dizzy to have a little bit being off in your vestibular system to just throw you off with your balance or your mobility. Vision. We all talk about our glasses and our vision, and you've got, how many people have progressive eyeglasses? All right. Ever notice how it's a little challenging to walk down a set of stairs or walk down an incline or step off a curb if you look through the lower level, right? So it's knowing how to manage that. If you have bifocals, similar thing. We also have the issues as we get older is macular degeneration and glaucoma and, you know, cataracts, right? You got to wait till they ripen, I hear. I'm hearing about this now. Yeah, my left eye.
It works.
It works, but you have to wait until they ripen, right? So what happens between that stage of waiting to ripen? I get a little nervous. You know, got to wait to ripen. But also, where I was going with vision, being up and moving around at night, driving at night, but just moving around safely in your own home at night can throw you off, right? Proprioception, just how you know where your body and your extremities and things are in space, just knowing where you are, right? That also happens through our joint receptors. And again, things change with time, unfortunately, but we just need to keep moving, right? Got to just keep at it. So common changes with age, we just talked about eyesight, the inner ear, sensation in your feet. How many people have heard of neuropathy? Yeah. That, if I could come up with an invention to cure neuropathy, I would be more than a multi-billionaire trillionaire. There is no real treatment for neuropathy. Neuropathy is, you know, I won't go into all the reasons for it, but if you're diabetic or you have other changes within sensation in your feet, people tell me it's like walking on sponges, right? So you don't feel your feet. You don't get that normal response, the old physics of reaction forces coming up through your body to know where your feet are in space, which screws up your proprioception, blah, blah, blah. All right, old injuries. All right, we got the crook in the knee, the cranky neck, the twisted back. All those things can add up over time and challenge our mobility. All right, medications. Michael, my other partner in crime here, will be talking about medications, but that also impacts a lot with your ability to move safely, as well as your cognition. So this all is coordinating. All right, proactive interventions. So aim to maintain functions of daily living, doing the things that matter to you. The best exercise in the world is what?
Walking.
What else? Moving. But anything you like to do. It doesn't have to be a certain exercise. And, do I have to go to the gym? Do I have to do this? No. Find something that you love and do it. And that's what's really important. Proactive interventions, activities, getting together with a friend, going for a walk. How many people know that the community center has walking time in the winter? Not that many. Okay. Very important. You can't mall walk in Peterborough. Right? So if you lived in Nashua or Manchester, they open up the malls at 7, 8 in the morning, and people walk around and get their Starbucks or their Dunkin' Donuts, and they meet their friends, and they see what's, window shopping. There's not that in Peterborough, right? So the community center is open. You can walk. I say, go get a cup of coffee before you go to Shaw's. Go for a walk inside the community center. Or do a few extra laps around Shaw's, right? Park a little farther away if it's safe. That's all important. Exercise. There's so many different options for exercise, okay? I put out there the flyer from the rec department in Peterborough. They have been adding on senior strength exercise programs and Tai Chi. They've also, the Grapevine in Antrim also runs exercise programs for seniors. Franklin Pierce University has started to get their undergrad exercise students to run each semester an 8-week free program at the Franklin Pierce bubble. So they're getting these students providing these exercise classes for people. So there's a lot out there, and it doesn't have to be really intimidating or difficult.
I found out that the gym on the right on the way to Jaffrey.
Yep, Performance Health.
Yeah, offers 3 senior health.
They do. They've been increasing their offerings. So they have a chair class, they have a mobility class, and they have a strength class.
Yeah,
Yep.
and they have an additional one. I wanted to give a plug for their
Yep.
Take Them at the Performance Center.
Yep.
And for instance, today, it's all the mobility.
Yep.
It's wrist, it's neck.
Yep. It's everything.
The whole series. And it's just brilliant.
It is.
The instructors are lovely.
They've been awesome.
They meet at 10 o'clock.
Yep. Pretty much 10 o'clock, all 3, Tuesday, Wednesday, Thursdays.
And if you buy 10 sessions, it's less than $9 a class.
Yeah.
For now.
So, and you can try them out for like a small amount, right? You can do for a class.
Nothing.
Yeah. So there are lots of options, a lot more than there used to be. So we're really excited. So that's being proactive, right? And finding out what's enjoyable to you or your friend or your family. It's making that self-care appointment with yourself and to keep moving. But my world is on the reactive interventions. So as much as we want to, keep promoting people to keep moving, reactively is when usually physical occupational therapy gets involved, right? When something has happened. You've had, God forbid, a fall or a twist or something that happened, knee replacement, hip replacement, an injury or whatever, fracture. That's when we get involved. But we also are proactive. So speaking to your provider when you go to see your primary care doctor about your concerns for your mobility. So talking about how safe do you feel getting around? Do you feel like you need to use an assistive device? And I always bring props, and I have to ask my Vanna prop to come on up. Lisa, have a seat, my dear. They're like, I don't want anybody to see me with my cane or a walker. I don't want them to think I have to use that, right? It's really hard to admit that we might need something. But what are these things?
Walking sticks.
Right, these are what the cool kids use, right? Right, my kids use these, right? They use them in the winter, they use them in the summer. Some of the winter ones come with little prongs on the bottom, okay? So these are cool, okay? Use them. They just provide that little extra, and you don't have to use both. Just times one. That's right, that's their job. Instead of doing what I call furniture walking, wall walking, and is anybody doing timing? Thank you, because I can talk forever, I told them that. But yeah, we wall walk. We furniture surf, right? Because you need that extra point of contact. So that's what these can sometimes provide. Doesn't mean you have to get to a rollator walker, though these are kind of handy dandy because they come with a seat. So if you feel like you do need to get out and walk, but you need a place to sit, make sure you put the brakes on first, and then you can have a seat, and then keep walking.
But I find with those, you stand up straighter than if you bend over.
Correct. Walkers and things, you need to have some help with getting them the appropriate height. but sometimes they run away from you too, right? You got to play catch up. But what I had Lisa here for is in your doctor's office, part of your annual physical, from what I understand, is a little bit of a walk test called a timed up and go test. Has anybody had that happen for them in their physical?
What did you call it?
A timed up and go, or a tug.
No.
Tug test. So it's an established test where physical therapists or even doctors' offices will ask you to sit in a regular chair, ask you to stand up, walk 10 feet, turn around, and come back and sit down. And what we lovely people we do is we get our little phones out and we try to find our our clock app, to get a stopwatch. And we say, Lisa, can you please stand up when I say go and walk to that point, whatever that 10 feet is, turn around, come back, and turn around all the way and have a safe seat. And she did that in 10.78 seconds. Anything under 12 seconds is considered normal. As you get above 12 seconds, then we get a little concerned, okay? The hard part might be getting out of the chair, right? The next hard part might be making the turn, right? And then the next hard part might be making sure you sit safely. So that's something to be aware of. The other thing that might be happening that we do in PT, and you can practice this is one of my best exercises you can do anywhere, literally anywhere, is I want you to, when I say go, stand up 5 times, and I'm going to time you to tell me how you can go sit to stand 5 times, okay? Without using your arms. You can put them anywhere but, okay, so ready, set, go. 1, 2, 3, yeah, 4, 5. Good, 7 seconds. So anything over 12 seconds shows some mild potential for mild to minimal risk for falling. When you get above 15 seconds and above 20 seconds, the studies show higher risk. So if there's one exercise you can do 100 times a day, no, I'm being a little over, is practice sit to stand. Because you got to get off the toilet, you got to get in and out of your car, you got to get on and off your chair, in and out of your bed. So if you have a few extra seconds in between those activities, do a few extra. All right, my Vanna, I've got the hook for the time because, like I said, I can talk forever. Thank you. And we'll take questions at the end, right? All righty, thank you all. All right, this goes to Flynn.
Thank you,
And
Lynn.
let's see, who's my next person up?
I am.
Oh, I didn't go into mobility. See, I don't use all my problems.
You didn't use your slide.
I don't use my slides.
You use
All
Lisa
right.
instead. You use Lisa instead.
I use Lisa.
Good evening. Thank you all for coming. So my name is Caroline, and I'm here to talk about mentation. And there is a definition up there by Webster's, but I think the biggest thing is we all know as we age, and it can be at any age, but we all change, whether you're 20 or you're 40 or you're 60 or more, okay? One of the things that is very common in a lot of patients I see, that as we age, which doesn't mean when you turn 65 or up, I see it in younger patients, but our hearing starts to change. There's a little bit of tinnitus. Maybe you listened to too much rock music, you went to too many concerts. It's true, right? Maybe you were even in a band. You worked on military, and you had flights and you were out on the boats. I'm from Florida, a lot of military. So those things make it more difficult as we get older to stay engaged in conversation, to stay active. Well, if you don't know what's being said, you have a tendency to withdraw a little because you're shy normally to say, "What did you say? What did you say?" You could be like a lot of people, they don't want to wear hearing aids. It's not attractive. Well, those are things that can lead to part of the problems with mentation, which is going to be depression. And I don't know exactly how to do that. Nope. Wrong way, so sorry. There we go. Depression. So, again, like I said, depression, mentation, it is not age dependent of a certain bracket. It can happen to anyone. So these are the things that isolate you, keep you away from socializing. You're sad, maybe you've lost your family, maybe your husband has passed, maybe you've even lost a child. These are very difficult things. So you need to speak to your caregiver, to your primary care doctor, to someone. There is help, and that's what I want you to know. For everything, there is help. With help, you have to know that there is dementia, but dementia is like an umbrella term. It covers more than just dementia, Alzheimer's. It's also vascular dementia. These are two very separate things. Also, people can confuse with delirium. But right now on dementia, I want you to know that vascular dementia is something that is basically due to strokes, okay, to traumatic brain injury, which could be from an auto accident, a motorcycle accident. I've had friends that they climbed a tree to help a cat down. Literally, this is a true story. And they fell 10 feet. Okay, so these things can cause that. So that is very different. And with vascular dementia, you will see changes in a person as they age. You will see it mainly manifest in behavior, in personality, because there's some brain damage, right? From strokes, ischemia, from just a physical blow. So you will start to see that. For caregivers, because a lot of people here could be caregivers, that's what you're going to start to notice, okay? With Alzheimer's, it's different. It is very progressive. It is not curable, but it takes on changes. And you can see that there's an early stage. And I'm not going to read to you because I'm not that person. And I know you can read, and I saw that they gave you big papers, which for me who wears glasses, and yes, they are progressive, I need that. But you have mild cognitive decline. And you don't always think of that because currently your grandchild, your daughter, your son, your husband, yourself, who doesn't forget where they put their keys? Who doesn't forget where they put their glasses when they take them off if you have real vision problem? If you don't put it in the same place, you lose it and you can't remember. These things are common. Is that dementia? No. That's having a lot on your mind. However, that can occur with dementia as it starts and progresses. The second stage is going to be the longest phase. Okay, that can go for a very long time. And that's when it progresses beyond, I don't know where I put my glasses or my keys, but where was I driving to? Where is the house? You know, I don't know where I am right now. And what you'll see is people have a tendency to want to cover up for themselves because you don't want to say, I don't know where I am. So you kind of fake it a little, but it is a progression, okay? And your family and your loved ones will start to see these things, but it exposes the person with the condition to risk for falling, risk for getting confused, getting in a car, maybe having an accident. These are all things you have to consider. Loved ones have to consider it for their family member, okay? The last phase is late phase. And when you have that, you forget to eat. And I don't mean you just got busy, but you forget self-care. You forget to take in food and nourishment and fluids. And this is when you absolutely need to have already made plans for someone to help you, okay? Because you're going to need a full-time person, whether you are going to be in like an assisted living or a long-term care facility, or you're going to have someone come and live with you or come and check on you every single day. And these are things that have to be planned. The last thing that people get confused with is dementia or delirium. And delirium is something that can be fixed. It is simply something that is from illness, a urinary tract infection, and it can be fixed. But it is a sudden onset, and then it is gone. So how do we diagnose? There's not a key for diagnosing, but doctors will run lab tests. They will do cognitive tests like they've talked about. They will do a mini mental state exam. And I know some of you may have seen the clock, okay? Yes, I know, okay. But there are many things that they do. Diagnosing takes some time. So it's most important that you know that dementia isn't reversible, but you can live a long life still with it. You have to prepare for it. Delirium is a fast onset and due to an illness. And things that you can do is you can exercise. You can stay socially active. You can engage your brain with puzzles, card games, and honestly, you can use the Mediterranean diet. And I left some out there for you guys. It is research proven to help with the brain. Avoid TV and avoid processed foods. Yes, ma'am.
What is ADL?
Okay, go ahead.
No, go for it.
Okay, they are the activities of daily living. Washing your hair, going to the bathroom, brushing your teeth.
Just didn't know the app.
No, and I'm sorry, I should have probably spelled that out. And TBI is traumatic brain injury, MS, and ETOH is alcohol. Okay, thank you.
So they invited the little kid to come and talk about the medication side of things. So, well, just turned 54 just a few weeks ago, so I'm creeping up there a little bit, but I'm sure a lot of you think I'm still a kid. So my name is Mike Flynn. I'm the pharmacy director here. I've been here for over 20 years myself. Previously to that, I came out of the long-term care industry, so I spent a lot of time working with nursing homes and consulting on patients that resided in nursing homes. So talking about our aging population is very passionate to me and understanding where things are for everybody. And medications are, one of the essential tools that we use in healthcare to help improve people's life and improve their life expectancy. Quick poll of the audience. How many people take one med on a daily basis at a minimum? Okay, so good shot, right? At least something or a supplement, right? How many take multiple, right? I'm 54 and I take multiple, right? And some of that has to do with my family history, right? So I have hypertension, right? And, hypercholesterolemia. So I have to take something for my cholesterol and I have to take something for my blood pressure. So it's easy to wind up in what we call polypharmacy or where you're taking multiple medications. And so thinking about our medication, wrong direction, where I'm going the wrong way now, see? There we go. All right. So when we start thinking about meds, right, we want to make sure that people are taking the most ideal meds that they can do. And what we're looking for are the medications that are going to provide you the most benefit with the least amount of adverse effects that are associated with it. And so any medication that you take, it doesn't matter whether it's aspirin or Tylenol or something more complex that you take for like your blood pressure. It has its good, which we call the benefit, and then it has sometimes we refer to it as the risks or the side effects of the medication, which are the things, the unintentional aspects that can happen with those meds. So I'm going to talk a little bit about three kind of primary aspects when we think about aging populations and where that goes. And that's we as providers, those of you that are helping guide you through your healthcare journey. And that includes physicians and nurse practitioners and pharmacists and nurses. And we're all part of your provider group that help navigate these waters with you. We have a level of responsibility of making sure that we're trying to put you on the most effective medication that works for you. And so I'm going to talk a little bit about the provider's responsibility. I'm going to talk a little bit about, the Beers list, which is a list of medications that we try to avoid in an aging population. And then I'm going to talk a little bit about what your responsibility is as a patient. But when we start thinking about like the appropriate meds for adults to take that are in the aging population, right, we want to make sure that we're thinking about things like your mentation. We want to think about your mobility. How can we improve those and or not make them worse by providing different medications for you? So as providers, that's a heavy thought for us when we're working through. We have a responsibility to make sure you understand your medications, right? Ensuring that you understand why you're taking it, what it can do for you, the benefits of it, as well as explaining to you what are some of the side effects that you might anticipate seeing. Right? We want you to be pain-free, but we don't want you to be so pain-free that you're unable to drive your car, right, effectively, or something, or inadvertently affect some of your ADLs, your daily activities that you do. So we want to make sure that we're educating you, understand where that. Things that we take into consideration when we're looking at it, your age, right, your medical history, some of the symptoms that you're seeing, your health conditions that you have, and also we're rolling that in with the other meds that you're taking, right? Because if I'm just taking one med, right, I've got to think about my medical conditions and different things, but as soon as I add another med, and it doesn't have to be a prescription med, it could be your local supplement that you're taking. People have probably heard St. John's wort, right? St. John's wort, which is a very common supplement that people take for mental stability, or not stability, but enhancement. It has a lot of different reactions with different medications that are out there. So it's something to take into consideration as we walk through different pieces. So the Beers criteria that got established back in 1991-ish, I think, Dr. Martin Beers, who was a geriatric physician specialized, started to recognize that a lot of his patients that were greater than 65 were experiencing a lot more effects to medications than a younger population. So he and his professional group got together and started to publish what we call the Beers criteria. What they did is they looked at medications that affected the aging population in a different way to provide a level of guidance to providers. It's not a list of never drugs for people to take, but it's establishing a list of medications that affect the elderly population in a slightly different way for those of us that are working on their meds and trying to point them in the right direction to find the most appropriate med for them to work with. So the American Geriatric Society created a list. It's published about every 3 years or updated. So you can imagine since 1991 how many drugs have come out on the market, right, in 30 some odd years. Pretty big list. But they really focus at, trying to make sure the current meds that are out on the market. So you see some things come on the market and go off the market. Well, they go on the list and they come off the list. And if you're computer savvy and you want to go out and you want to Google it, you can Google the Beers list and you can look at it. It's a lovely 52-page document written like a medical journal, right? So it's super easy, right, to kind of read through and kind of think about like what's on here and where does it go. It's really meant as a guide to medical providers to provide a level of education and support to individuals like myself or your PCP, or to help guide us when we're looking at the appropriate meds for people to take. So what we think about when we're looking at Beers list is what are the best drugs for you to work through. And so when we think about what's on the list, we classify them as potentially inappropriate medications, right? Keyword potentially. Doesn't mean that just because it's on the list doesn't mean that you can't take it. But those, are meds where we start to look at, and you've probably heard the term risk versus benefits, right? When we start looking at medications, as we age, that changes a little bit, right? And so maybe the risks start to get a little bit higher than the benefits that I'm going to get out of that med. And so as that scale shifts for the elderly population, we start to think about, is it an appropriate medication now to use? That's kind of how we gauge and establish what goes on this list. When the risks start exceeding the benefits, it's potentially, not the best choice. They're split into 5 different categories in there, and we won't belabor all of that right now. But really, it's thinking about, there are medications that we probably want to consider, are inappropriate. Then there are medications that might be inappropriate in certain diseases, right? As we age, we have a tendency to pick up certain diseases. Sometimes we lose kidney function, right? And if I lose kidney function, then that's an area that there are certain meds that I probably don't want to use on somebody that has poor kidney function. So there's a category of looking at, disease state, and consideration around that. There are also ones that are avoid if possible in the list. Those are the big older drugs that have they have a tendency to have a lot of cognitive impact. Those are things like anticholinergics, old medications like amitriptyline, things that we used to use in the past for certain things. But there are some very common drugs, I want to be clear, on the beers list out there. Diphenhydramine. How many people here have ever taken Benadryl? Right? You've got an itch, maybe you take it to go to sleep, maybe you take it to do something else. Technically, it's on the beers list. It doesn't mean that it's not a good medication for you to utilize. It just means take some consideration where it's going. And as a prescriber, would I use it as a mainline therapy for you when I kind of go through different things? Non-steroidal anti-inflammatories, another category of drugs. So things like ibuprofen that you may take or leave, technically on the beers list, right? So why? Because in certain patient populations, right, that may have reduced kidney function or what have you, they might not be the best choice. Now, how do you navigate that, through that, right, and your responsibilities in working through what the medications are for that is pretty easy. It's about being informed, right? There's thousands of medications out there, and we could spend hours if you wanted to be geeky, and we could talk about the different chemical structures and all that fun stuff. But at the basis of it, it's about you making informed decisions with your provider as to what's the most appropriate medication for you to be taking. And so that starts off with understanding what you're taking and why, right? And so we encourage that you get inquisitive with your providers. I've met many patients that say, I don't know why the doctor put on them. And I said, well, did you ask them why? Well, no. They just, they said my blood pressure was high, so they put me on this. I said, okay, did they talk? So don't be afraid to ask the question, right? That's part of their responsibility, is to provide some of that education to you, as well as it's yours to understand. And, there are some great questions that you can kind of ask, to go is, could this medication offset or, potentially affect my balance or how I think? Right? So you're starting a new medication. If you're worried about your mentation or your mobility, you can ask questions that are related to that. Is it going to make it more difficult for me to walk? Right? If you're already struggling with mobility, you could ask, is it on the beers list? Right? We know that's a national published list that's out there. That would spark a level of conversation. You could ask, could you review this medication with me and explain to me why it's beneficial to me and what I can expect for side effects, right? That's probably one of the clearest pieces of understanding, why is the doctor putting me on a new medication? And at that same time, what do I anticipate that it might do? Is it going to make me sleepy? Maybe it is, maybe it's not. Maybe if it does make you sleepy, I don't want you to take it. So I want to have that conversation with you to make sure that if you are starting to have some of those side effects, that you're identifying. I think one of the biggest questions that you can ask a doctor or a medical provider is, when can I stop taking this medication? And so we call it deprescribing, and it has a tendency to not happen often. And that's a great conversation for patients to advocate for, or if you're with a loved one, to advocate about what they're at. Because just because we started a medication today doesn't mean I'm necessarily on it for the rest of my life, right? But in the transition of your healthcare, sometimes you don't get your healthcare all from a single provider, right? You might have your primary care provider, you might have a cardiologist, you might have an endocrinologist, you could have another specialist that's out there, all of whom are writing different medications for you and treating different pieces of it, of your medical condition, and making sure you're having that conversation, in my opinion, at least with your primary care, to make sure they're looking at you holistically, which I know many of our providers do, and take that time is important. So asking those questions and sharing your information with your PCPs. So always maintaining an accurate list is great, and making sure that you keep that up to date. And on the screen, there's lots of ways to kind of look at it. The other piece I advocate for in anything I do talking medication is safe storage and disposal of meds. Don't hold on to old stuff. All too often, I've gone to somebody's house and they're like, well, I had that prescription from like 5 years ago, so I kind of felt that way, so I just took some of it. Well, that's not the right choice in that moment. Ideally, if you need help, you're going to seek help, and we'll put you on something that's probably more appropriate for you. But disposing of old medications is important. How many people know that the town of Peterborough, the Peterborough Police Department, has a drug take-back box? So if you have any old prescription medications and you're wondering about how to dispose of them, it's a great way to dispose of them. They get sent back, no questions asked. Not everywhere has that. You can check with your local landfill to see about what their disposal process is. I know mine in the town of Walpole, New Hampshire, they tell you to put it in like a Tide bottle, tape it off, and label it that it says old drugs, and then they dispose of it accordingly. So check with your local area to find out. There are also some pharmacies that will take them back as well when you have an unused portion, but working through that. So I'm sure there'll be questions on meds, and we'll talk that when we get there. Molly?
All right, my name's Molly Rainimi. I work in what's effectively the quality department here, and one of my primary job duties is patient experience. So some of that is complaints resolution, some of that is patient advocacy if somebody needs help navigating the healthcare system. So that's sort of the perspective that I'm taking to this last of the M's, which is a little bit of a stretch because it's what matters, but they count it as an M, the fourth M here. And what matters is really the core of the 4 M's, right? Because you heard all the other presenters say, when you are thinking about what matters to you and the things you prioritize and the elements of your healthcare that you're unsteady about or concerned about, it all comes down to what is important to you and what do you want to maximize. So when you are thoughtful about your medication usage, that helps you maintain and make sure you're not adversely affecting your mobility or your cognition. And when your mobility is preserved, whether that's through using assistive devices or not, or just focusing on your well-being and exercise, that helps you go to the places that you want to go. And when your mentation is managed, even if there is cognitive decline, that means that you are finding those supports and those resources in your life so you can show up and be present to the very best of your ability and your current capacity. And when we talk about what matters and planning for the future, we have to talk about autonomy. Autonomy is your right to make decisions about yourself, your body, your own health care, right? Talking about the risks and benefits of a medication. You can be explained that, and if you have the ability, if you are competent to understand that, you think, all right, this is worth it. They're telling me that it'll help this condition, and maybe it'll make me a little sleepy, but I think that risk is worth taking right now, right? So autonomy is being able to have your own voice in your healthcare experience. And when we talk about autonomy, we want to maintain that autonomy into the future. So if there is a point in time where you are incapacitated, and that doesn't have to be an age-specific conversation, really. Anyone could go out and be in an unfortunate car accident and become incapacitated, and there's going to be someone who's going to need to make your decisions. You can have a planned surgery and you're under anesthesia, and a decision needs to be made when you're not conscious, right? So this isn't all just end-of-life considerations, but when you think about things like your advanced directives, assigning a power of attorney, that's the person who's legally designated to make your decisions if you become unable for any reason, whether it's planned, unplanned, advanced Alzheimer's or dementia, right? You want to be making those decisions when you're well, so your autonomy can extend to the future when maybe you can't literally voice those wishes. And this advanced directives in New Hampshire, shameless plug, we have another health and wellness seminar coming up in June on this topic specifically. But just at a high level, advanced directives are two parts. That durable power of attorney for healthcare, the person who makes your decisions for you if you cannot, and the living will, which is in very broad strokes, would you want all of the life-sustaining treatments if you were in critical condition, or would you only want those if you had a good prognosis or hope of recovery, right? Very broad strokes. But what it does is it articulates what your desires are so you can maintain that autonomy should you ever find yourself in that position. And again, making those decisions when you are well and thinking clearly and calmly, when you're communicating that to your loved ones and who you are assigning as your durable power of attorney for healthcare, has value not only to you in maintaining your voice, but also to your loved ones. Right, so my little quote up there from Brene Brown, clear is kind, that really speaks true here, because if you are in a critical condition where someone's making your healthcare choices for you, that's heavy no matter what. But it's a lot heavier if you're like, I don't know what mom wanted. Did I make the right choice for her, right? So making sure these communications are done thoughtfully and in advance helps maintain your autonomy and helps your caregivers and your family care for you the way that you would want to be cared for, and, in touch with what matters to you. But of course, what matters to you is not just sort of the end of the journey and like the dark space there, right? There's plenty of life to be lived. It's the journey, not the destination. And so what matters to you, of course, is also what are you doing with your time? Where are you prioritizing your hobbies, sports, being at home with your grandkids, or tending to your pets, or going on hikes? All those things. Is that my cell phone? Well, look at that. I need to give a diabetic cat insulin, except I'm no longer cat sitting, so we're all set. He's keeping his medications in line with his provider's advice. So what matters to you? And that could be truly anything. If you like doing crossword puzzles, great. If you like knitting, if you like pickleball, keeping active, as Lynn was talking about, right? Those are the things that matter to you. And how that dovetails into your healthcare experience is to say that if you're finding barriers to doing those activities and hobbies and sports and spending time with people, right? If you have your hearing loss and spending time with your family now is you isolating, like Carolyn mentioned, right? Not being able to engage in conversation, that's worth bringing up to your provider, right? To talk about, I'm having some concerns about hearing loss. Or I've been trying to play pickleball, but I had to quit because my shoulder hurts, right? Any of these things can fit into the puzzle of your healthcare experience. And it does take a little bit of advocacy on behalf of the patient, right? Some self-advocacy to say, this isn't on the checklist. I don't go to my doctor's office and they say, I need your height, your weight, your blood pressure, and yes or no, do you like pickleball? Like, some of these things are going to have to be expressed and articulated because it might not hit a checklist. So it does take a little bit of advocacy, but it's worth mentioning, and it does help us, as a very broad we, as healthcare providers, to understand who you are as an individual, what matters to you, and how we can supplement your healthcare beyond that preventative care checklist or keeping up with the chronic conditions. Yeah, we already know you have arthritis. We've been coming here for 15 years about it. We got it, right? It takes speaking up. And this next slide here is about social determinants of health. So this is basically the study of what makes somebody have better health outcomes than another. And some of this is population health-based, sociologically based. And the slightly depressing statistic here is that only about 20% of your health outcomes is directly related to the clinical care you receive. You could have the absolute best doctor in the world, but if they prescribe you a medication you can't afford, your health outcome is going to suffer. Again, you could be going to that top-notch doctor, world class, and if you can't get to the appointment, you're not going to receive that care, right? Socioeconomic factors, your financial ability to pay, your education, your job status, your physical environment, clean air, clean water, things like that, your housing arrangement. All of these factors contribute to who you are as a person. And the reason this is important in this scenario is because that's the lens through which you should be viewed as a patient, as a real person who lives in a house somewhere, who has a budget, who has those hobbies that they want to have access to long term. And it's not to say that your access or your abilities won't change over time, but understanding all the things that make you you as individuals really is pertinent to your care providers, thinking about the best way for you to access your resources, tap into your community, and then engaging all those clinical aspects that they think would help facilitate all those things that matter to you. So maybe it's a little cheesy, but in healthcare, it's not just what's the matter, it's what matters to you, right? And again, this takes some patient advocacy. You've got your routine touch points, you've got your physical exams, your annual Medicare wellness visits. Those are all great opportunities to say, you know, this is something that's been bothering me. And really taking up the opportunity, sometimes it can be seen as just sort of small talk, like, how have you been lately? It's like, I'm fine. Get to the questions, right? Ask me how much I've been sleeping and how many vegetables I eat, right? They've got the checklist of things that they're gonna talk about. But this really is genuinely meant as your opportunity to say, like, yeah, really, my knee has been bothering me. I can't hike like I used to. I can't go out and clean the chicken coop because it makes me wheeze. Whatever your circumstances are in life, right? It's also worth mentioning at acute care opportunities. Have you just had a surgery, a fall, an unexpected emergency department admission, or an admission to a hospital floor? And maybe they are changing your medications, or maybe you were discharged and they recommend you use an assisted device like a cane, right? How are those things impacting the things we've already been talking about? How does my new medication affect my old one? How does using an assisted device, you know, limit me or open doors for me out in the community, right? Because you think about buildings and accessibility and all that. Society was really built for the peak of like human physical performance, right? They don't build a new home with ramps and elevators. They build it with stairs and they say, yeah, that's the second floor, you know? And that doesn't take into account disability in general. It doesn't take account the normal aging process and your mobility and how that changes. And it doesn't take into account the fact that perfectly fit and healthy young people can get injured too, right? So leaning into those opportunities to be successful is what all of this is all about. If I didn't wear my glasses, all of your faces just disappeared. I can't see anything, right? This is a very normalized accessibility device with glasses. Some of the stuff Lynn showed, maybe people haven't quite normalized yet in society. Maybe with our 10,000 baby boomers turning 65 every day, it will be. But the point is to enable you to be successful. So the encouragement to speak up, to take advantage of those opportunities. You're at the pharmacy and they ask if you want any counseling from the pharmacist, maybe you want to say yes, instead of saying knee-jerk reaction, no, like my doctor said it was fine, I got it, right? And you can always reach out to your provider's office on the fly as well, right? Whether that's the portal or a phone call. Some things can be resolved over a phone call. Maybe they say, great, I'll send you a referral, or great, I'll order an x-ray. Maybe it requires an office visit or a referral to a specialist. Maybe you can resolve it in a question, but the point is to speak up so that we can really address those things that matter to you and talk to you about it so that we can find those solutions. All right, we are pivoting to question time. Christy Sue is going to be our MC for this, but you are welcome to ask questions to any and all of us, or Christy Sue.
Or me. Be happy to answer anything. Yes.
Is it a sort of a touchy question to ask your primary care if you could have a consult with the pharmacist about the drug that she has chosen?
No, I'm going to.
Absolutely not. So, you know, obviously it's not a time to argue necessarily. But the reality is, you know, we refer to providers, and I kind of hinted to it, of a provider isn't just your PCP. It's not just your specialist. It's all of us that are involved in your health care, right? And that's the CVS pharmacist, the Rite Aid pharmacist. We're all part of that team. And so our goal in that is to make sure you have the most optimal outcome that you have. And nurse practitioners call me all the time for our hospital group, even though, you know, the primary care doctors call our pharmacy. Even though we're not dispensing to the public, we're consulting with them if they're not sure what to do. So we consult in that fashion, but even when patients have questions, When I worked retail, it wasn't uncommon for me to call up a doctor's office and say, hey, Mrs. Smith was in, and she's a little, concerned that she's taking this medication and it's not working as well for her. How do you want me to advise her? Do you want to see her? Do you want to do different pieces? So we'll act professionally on that, but it's not inappropriate for you to question, is this the best drug for me to be on? And you can ask that of your pharmacist as well as the prescriber who's actually writing it.
But what I'm saying is, can I go to the hospital pharmacy director and have a meeting with him myself?
So one of the programs that we don't have here at this organization is what we call ambulatory care pharmacy. So our pharmacy staff here are kind of already dedicated to different functions. So we don't necessarily directly interface in. If it's a unique circumstance, we'll find a resource for you to talk to. I would say wherever you get your medications filled, and many of you probably get them from a mail order pharmacy, there are pharmacists available via phone there as well. I would start with your primary care before you walk up to the pharmacy window here at the hospital, but we'll field your question as best we can. But ambulatory pharmacists that work in the practice, that's actually what they do. They actually spend time, they make appointments with patients, and that's a goal that we have as a future goal somewhere in this organization. We're not there, and Rich would shoot me because I'm saying it out loud without it, but that is a goal. That's a goal for me and where I see our pharmacy department growing as an organization is to get the pharmacists more into the outpatient setting, built into the practice, doing what we call medication therapy management, or MTM. And that's looking at, with your provider, what patients are getting for medications, are they the most appropriate, and having those direct conversations with patients. So I would encourage you to be inquisitive with your PCP, be inquisitive of the pharmacists that you're getting your medications filled with, because they can help you with that as well at looking at. It's also why we recommend that you try and, as much as possible, it's not as easy as it used to be, to single source, I call it, get all of your medications from one location, because then that pharmacist can see everything that you're on much easier than trying to figure out what 7 different doctors you have with different medical records and what's out there. So your pharmacist is often that gatekeeper of that consolidated list.
But how does one go to the local pharmacy
Mm-hmm.
and there are 12 people working inside it, and there are about 15 people waiting in line to get a prescription?
It's not easy. It's not set up well, is it?
And me have a personal conversation at this depth and this level, at this concern, when they're so busy. How do you do that?
It's a challenge.
And it can't be an intimate setting. I mean,
No.
there's all these people surrounding you type thing, and now you're gonna ask these deep questions about your personal health care?
Yeah,
You
it's
go to information and then they'll have the pharmacist come talk to you.
you can. And
Yeah.
in all honesty, I would never ever hesitate as a patient to say I'd like to speak to the pharmacist. And they may not be able to speak to you in that moment in a piece of it, but absolutely when Molly talked about there's a little bit of self-advocacy in what you do, ask them, is there a time that I could come back and we could kind of go over my medications?
Make an
This
appointment.
time for them.
Well, it may be. It may be something that they have to build into their schedule for that day, and and it's not easy when there's one pharmacist and multiple techs, and they're trying to get everybody's medication filled timely and given vaccines and all those different intervals that they're working on. I can't speak for their time, but as a profession, our goal is to provide counseling, and if you ask for counseling, it is our obligation to provide it to you, and that includes counseling. Doesn't mean just about this drug. It can be about all the drugs that you're on.
And
So- Yeah.
Does Dartmouth Hitchcock Medical Center in Keene, do they have a consulting pharmacy?
So they do not have an ambulatory program either at there. We call it ambulatory. Their Dartmouth Health System does in several of their settings. Cheshire currently does not, to my knowledge, but I could be wrong. But that's kind of the future of where pharmacy is kind of going. It's getting a little bit more integrated. So, but we can talk offline too as well if you like.
The VA does have
Yep.
this. They have a team of healthcare.
Yep.
It is your primary care, it is your nurse, it is your pharmacist, it is your social worker, it is your care manager where you might require special assistive devices.
Absolutely.
That is your care team at the VA hospital. That's works pretty good.
It's a pretty impressive model, and we do that for at an inpatient level.
Correct.
When someone's here as an inpatient, we actually round daily on every patient that's here, and it's a multidisciplinary team that meets and discusses and reviews all of that aspects of our patients that are inpatient.
Should be.
We're not quite there yet on the outpatient scheme to be able to have that same type of level. Is that the future of healthcare? I hope so.
Well, I'm encouraged by your comments. Thank you.
You're welcome.
Does anybody else have any other questions?
Other than how am I going to get to my car through all the rain?
I know, I was like,
We'll just hang out here, 'cause I'm not
right,
going
because I'm not
out
going,
back.
yes, you had a question?
Yeah, just in general, being here, having PCP, went to another doctor here, they put me on medication, I said, I can't be on that. Went back to the other doctors after, and they said, why did that doctor even put you on that when it's in your records? You can't have this. How do you fight that within the internal system of the Monadnock Hospital? It's in the records, you can't have this, but they give it to you.
Yeah, so it's a challenge. You know, there's so much around medications and how they flow and what information is provided. And we do something we call a process called med reconciliation. And that's our hope, is that every time we interface with a patient, you probably get asked the questions like, have you started any new medications? And the medical assistant or your nurse practitioner or whoever's kind of interviewing for that is making, jotting that down and hopefully getting it into our healthcare. Here at this organization, we have 2 electronic medical records. And they're separate, and you fall in Dartmouth, right? There's another medical record. Although there is some information that's passed back and forth digitally between these systems, not all of it gets passed forth, so sometimes it can get missed. So for your unique circumstance, I don't know if it was an omission in the record, or if they were looking at a different record at a different time that didn't have the updated list with it,
Just
so.
don't bother, take the time to look.
I can't answer that necessarily
That
without.
was a doctor, they're different.
Well, and that could be to some extent, but there are also times that it's not inappropriate, depending on what's on your list and why you weren't supposed to take it. Again, I talk risk versus benefit. That scale kind of shifts depending on what's happening for different things. And there are times when the risk might have outweighed the benefit that's associated with taking a medication, and later as you age or your medical condition changes, it can happen. It happens to me. Even that now all of a sudden my blood pressure medication's not working as good as it did, and I had a medication, and no, we're going to switch you back to that one because actually it gave more benefit than the rest that are associated with it. So sometimes that pendulum can switch, but it's an educated decision between the provider and looking at what you need. So I can't answer the specifics on what happened on yours, but there's a multitude of things that can happen with that aspect, and I'm sorry that that's an experience that you had. But it does go to show that self-advocacy and asking those questions are important. Don't just take it at face value, then ask the question. If you have a question in your head when you're working with a healthcare provider, ask it. But if there's nothing else you walk away with, is don't ever be afraid to ask a question of a healthcare provider.
I always make a list before I go.
And that's
Excellent.
fantastic.
Excuse me, I love that.
In all honesty, when I've done, I would call it MTM medication therapy minute, when I've sat with people and done that consulting, I absolutely love that as well. Like, I would way rather have someone that's
Because
coming
I'm afraid I'll
engaged.
forget something.
Well,
Absolutely.
I forgot the list this morning, okay? I walked in there and I said, darn it, I left the list on the table. I finally actually wrote it all out. But I remember most of it because I wrote it out, right? So when you write things by hand, you remember better.
Sure.
Yep.
Absolutely.
All
Your
right.
grocery list.
And one other thing, you said the take meds back at the PD here.
Yep.
Yep.
Unless they changed it, they don't take liquid meds.
So it depends, right? It depends on the different programs, and they may have a sign up that says that they don't take liquid meds. So that could be. I haven't been down. Originally, they took anything and everything, but that very well could be. There are some programs based on what they're doing that they can't do liquids. They can just take tabs, caps, and other things like that.
Right.
So.
All right. Well, thank you everybody for staying. We know that we're a little over time because of our special guests that we had in the beginning. I know.
Yes, indeed.
But if anybody has, any other questions or whatnot, we'll be hanging around for a little bit. If you guys have some other questions or concerns. All right. Thank you everybody for coming.
Thank you.
Okay.